Jens and Rob, thanks for having us here. This is an incredible program. I remember as a resident and fellow hearing about this all the time, and something you've built locally to this community and nationally and even internationally. So it's fun to be here, and this is sort of a fun topic, sort of the ergonomics in surgery and how we avoid becoming our own patients. These are my disclosures, none of which are relevant because they can all cause ergonomic problems. But here's the outline, right? I just wanted to start with a couple stories and sort of go through why we suffer what we do and then how we can eventually improve, and then what the role of these new enabling technologies are. So when I started sort of becoming interested in this topic, I realized I hope people don't think, as we become millennial, like the millennial sort of generation is now becoming surgeons, that we just like to complain about everything possible, including sort of our own discomfort over time. But what we see in sort of our world of surgery is, look, right, it's this orthopedic surgeon, years of pain from a herniated disc, finally undergoes spine surgery. Cranial surgeon, like lots of intense hours of physical demands, altering their practice as different surgical modalities over time because of the discomfort of their surgeries. The neurosurgeon who kind of takes a leave of absence because of chronic back pain, hunching over an operating room table. Or the deformity surgeon who ultimately decides that they just can't perform surgery anymore because of the toll the operating room has taken on their bodies. So, they're more than just cautionary tales at this point, right? These are sort of serious, albeit largely unspoken daily realities that we face. And it's not just in spine surgery, it's across all modalities and different stages of our careers at this point. So, why do we as surgeons put up with this, right? Well, each surgical modality has its own set of unique ergonomic risks. And as surgeons, we often recognize these risks, but we rarely report them to our institutions. We sort of just keep these in conversations amongst ourselves. And there's this culture of silent suffering that we've sort of trained through in our years of training and even in our early careers as attendings, because that's the status quo, right? We do know that there are some ergonomic guidelines that exist, but no one really receives any ergonomic training during residency or fellowship, right? And the study of ergonomics in surgery is limited because it's logistically very difficult and it's incredibly expensive. Right. So what is the actual problem, right? If you look at these surveys of different surgical groups, right, 70% of surgeons, and this is 5,000 reported some sort of pain, often in the back or neck. And if you look at tumor surgeons, you can see where the spread of the musculoskeletal pain is, again, a lot in the back and the neck. If you look at the systematic review that's out there, looking at sort of analysis of surgical ergonomics against or across multiple fields, again, you're seeing that the pain is widespread, and we're looking at almost 2/3 to three-quarters of all surgeons complaining of some sort of musculoskeletal pain after surgery, both in an acute and chronic setting, right? So, what exactly is ergonomics, right? Well, it derives from the Greek term ergon, meaning labor, and nomia, meaning arrangement. And so the concept is, right, how do you design a working environment to fit the worker, right? Instead of the other way around, which is what we often do in our operating rooms and even in clinic, is forcing the worker, which is us, to sort of fit in this working environment that we've been provided. And so, why is surgery so far behind the other workforces, right? If we look at other manual labor positions, why is the field of surgery so far behind? And I think that we see that there's just so few formalized ergonomic programs that have been implemented for surgeons. Again, it's underreported and it's really difficult to study. So let's dive into some of these ergonomic concerns. Right. So, as spine surgeons, speaking to a group of spine surgeons, we are incredibly stubborn in a lot of things that we do. Right. But the principles and problems and all these preventative measures and proposed solutions, are widely applicable across all specialties. So why are we at such high risk, right? If you look at this picture, right, we operate in a lot of non-neutral positions. It's a lot of repetitive, forceful motions. I mean, think about how your forearm feels after just a few kerrison bites over an extended period of time. And a lot of non-ergonomic instrumentation where wrists are put in precarious positions. So if you look at a lot of these studies now focused on neurosurgeons and orthopedic surgeons, sort of late in career, early in career, and in training, what we see is this, right? So this is from our orthopedic academy looking at occupational related cervical spine disease in orthopedic surgeons. 60% of respondents reported neck pain. 23% reported cervical radiculopathy. That's one in every four orthopedic surgeons have reported cervical radiculopathy. But only five surgeons out of 685 respondents um, ever really sought or ever described that they had ergonomic evaluations for the pain that they were experiencing. Or associated factors were older age, higher stress levels, and performing arthroscopy. And so we saw as cervical injuries are rarely reported, and the ergonomic workplace evaluations that are causing those symptoms are infrequent. How about in neurosurgery and spine surgery, right? Work-related musculoskeletal injuries can start early in the career, and they're often related to high operative volumes as well. And so we see this bimodal distribution of it's not just late career surgeons who are suffering from musculoskeletal injuries. It's a lot of residents and fellows that are in training, but often don't discuss it. Well, let's look at the orthopod residents, right? This is a great study out of Iowa where they evaluated the orthopedic surgery residents, and they saw similar rates of musculoskeletal symptoms in both the residents and the attendings themselves. And so, they concluded that we just need to pay more attention to the ergonomic and physical environments in which sort of training the next generation of surgeons, because clearly we're not doing a great job with that. And so when they dove deeper into these orthopedic residents, they sort of described, okay, well, what is the nature of this pain? When is it occurring and where is it occurring, right? If you look at after a full day of surgery, 42 plus 55, I mean, 97% of residents are feeling some type of pain after just a long day of surgery, between mild and significant, with almost 50% reporting some significant pain. And these often are younger bodies. Greater than 30 days out, there's a 50% or a fifth of the residents are describing chronic pain. And acute pain, obviously, three-quarters of the residents. How about the anatomic location? Again, it's the lower back and neck and the feet and the shoulders that are the largest culprits of our musculoskeletal pain. And how do people react, right? How does it change their behavior, their daily life? Well, you can see that, stamina is affected. A lot of residents are taking over-the-counter medications, but it messes with their concentration, their sleep, their degree of irritability, their intolerance and frustration. I mean, these are high percentages of sort of the backlash of this musculoskeletal pain that we're experiencing. What are the most common ergonomic approaches to minimize this procedure-related pain? Well, let's try changing our body positions over time, or changing our footwear. We always talk about and rave about the newest shoes that we buy because our feet feel better in surgery. Or 60% of people just simply ignore it, right? We just got to get through the case. I want to do more in surgery. I don't want to complain about it. And then when we look at the medical care that's being sought, again, it's 35, 40% have never sought care for it. Some people see, conservative modalities with over-the-counter medications and some massages and physical therapy, but only 10% are even going the step further to obtain diagnostic studies or even referral to any sort of specialist. So very largely being swept under the rug. How about in deformity surgeons, right? These are the longer procedures and certainly really, really difficult body positions over time, right? A lot of repetitive, forceful tasks, certainly mechanically disadvantaged. If you look at that table on the left where I've circled, those are pretty stark numbers, right? If you look at time off from work and the surgeons who have reported that, from lumbar disc herniations, a quarter of them underwent surgery for a microdisc. 40% for carpal tunnel, 15% for rotator cuff pathology, 10% went underwent surgery for cervical disc herniations, and a lot of people took time away from work because of the musculoskeletal injuries that they experienced, largely due to procedure-related pain. So we're really good at blaming others and blaming other things. So, what and who do we blame here? So if we look at some of the major culprits, I think everyone can agree that loops are one of the biggest culprits to the neck pain that we experience. And that's because it's the extreme neck flexion, right? There's, Elizabeth and I were talking earlier about the different designs of loops that there are now to help maintain a more of a neutral neck position. But if you look at a lot of us, we're still utilizing the standard loops where we're in this extreme flexion for an extended period of time. If they look at this study, looked at microsurgeons who were using loops, and 80% of surgeons who regularly use loops describes some sort of neck pain after surgery. And when you're in that neck flexion, your cervical load actually increases by 40%. So it's sort of funny. I found this study looking at the assessment of stresses in the cervical spine just by posture and position of your head, because right, everyone walks around the street looking down on their phones these days, and placing themselves in really difficult positions. But if you look at those numbers, right, every few degrees that you're flexing your neck, there's a significant amount of force that is now being applied to your cervical spine, right? So if we look at 60 degrees, which is our natural phone looking position, that's an additional 60 pounds of force to your cervical spine. And so if you think about it, the load of the head on the spine, as Enzo was sort of talking about in his talk, is 10 to 12 pounds in a neutral position. I mean, it goes to 60 when you're flexing to 60 degrees. And it impacts more than just your cervical lordosis and your neck pain, right? It also, you have a reactionary sort of postural change to compensate in your low back as well. The microscope's not the panacea or the answer either. Studies have looked at your eye strain after hours under a microscope. Even though you may be operating under more of a neutral position, your eye strain is now significantly worse. 25% of surgeons have complained of eye pain or eye strain after extended use of the microscope. And these symptoms are also associated with endoscopic surgery as well. And you can experience sort of this difficulty with vision and worse posture over time. Another culprit, the repetitive motions, the power tools, the rongeurs, right? It's these repetitive strain injuries in the upper extremities that are also quite problematic. And, 9 to 30% of surgeons, of spine surgeons specifically, have complained about carpal tunnel syndrome. Often the use of a kerosene punch rongeur, increased surgical time, and the time in practice are risk factors for that. Endoscopic procedures have been really touted as improving your overall posture because now you're operating with a neck in a more neutral position. But when you look closely at some of the ergonomic studies that have been done, you've now transferred that pain from your neck to your shoulders and elbow. For those of you who have been training under endoscopic procedures, think about how fatigued your elbows and shoulders and forearm were after your first procedures. You sort of just transferred that neck discomfort just down the chain a little bit. And so up to 50% of endoscopic surgeons have described shoulder pain after these types of surgeries. Radiation. We all know radiation is incredibly important, but lead aprons is also really, really heavy, right? These lead vests weigh between, 14 to 17 kilograms or 30 to 37 pounds sometimes. Try performing bicep curls with your lead apron. It's not the easiest task to do. And so this adds a significant amount of load to our low backs over time. And we do agree that radiation safety is incredibly important, but are there other ways that we can not transfer one nightmare to another? So what are the downstream impacts over time, right? It's not just the pain. We have studies that have shown that when they've implemented ergonomic evaluations and plans in their hospitals, they saw significant improvements in productivity, quality concern reports, safety records, and cost benefits, and that it can take as little as 8 months to actually pay back, the monetary investment in a safety initiative for ergonomic evaluations and interventions. Burnout and job dissatisfaction have been intimately tied to poor ergonomics and the musculoskeletal strain that we're experiencing. Our ability to make good decisions are impacted by the musculoskeletal pain that we're experiencing in the operating room. And ultimately, the concern is, are we impacting the safety of our patients when we're suffering from this pain and trying to operate through it? So in these last sort of couple of minutes here, okay, well, that's enough. What can we actually do about this? I think the easiest thing to be cognizant of is, where's the table height when you're operating, and where's the microscope? We've talked about how, if you can maintain as neutral or as natural of a standing position when you're operating, and even a microscope can take you sort of out of that position from time to time, that's really important. And sort of bringing your table height to the level of the umbilicus, that tends to be where your body, your elbows, your shoulders, your neck will maintain the most neutral position during those surgeries. Heads-up displays can be very helpful. There's a lot of technologies out there now that allow you to perform surgery looking at screens. Obviously, there's a learning curve and a safety factor with that, but it helps you maintain a more neutral position overall. Some studies have even utilized body supports to prevent lumbar strain over surgery. I'm not sure we want to jump to that type of intervention at this point, but it does show what's out there and what people are doing. Very modest modifications in our instruments and techniques can go a long way. When we talk about, instruments can be changed from free to anchored. Think about like cutting rods, right? Cutting it like this versus using a a table-mounted rod cutter, or inserting screws with power instead of instrumenting the whole spine using a manual gear shift and tap and screws, or even learning to train those around you and learning to safely delegate some tasks to your assistants under close supervision just to distribute the workload a little bit. So what does the position actually look like? Well, if you look at several studies done by JAMA, this is sort of what the optimal position is. And again, it's a lot of 90-degree positioning. Table at the level of the umbilicus, your arms and elbows, your neck, sort of in a neutral position. So to close this up, I just wanted to share some of the current research work we're doing in ergonomics because we're doing some fun work. And so we've partnered with this company where we now are wearing sensors on our bodies in surgery. They used it to develop a lot of Hollywood movies and animation. And they've worked with a lot of athletes and trying to study their movements for video games, really, and commercials. But you can also see sort of in manual labor positions where ergonomics in the workplace is so important that we've been starting to try to wear these sensors and partnering with this European company to actually gather meaningful data of where our bodies are in space, where our shoulders are, where our elbows are, where our wrists are, our neck, lower back, knees, hips. And based on literature out of ergonomic sort of studies, which positions and for what durations are we placing our joints and positions at increased risk of musculoskeletal injury over time. So at the end of the day, we're just trying to figure out how we can avoid becoming our own patients. So thanks for your time.
Great stuff, and so glad to have you with us, Philip. Where does physical fitness come in? I mean, you're showing that we're actually acting like athletes, but shouldn't we train ourselves for this also? And shouldn't we do things like being ambidextrous or trying to aspire towards ambidextrousy? Should we use microscopes? Oh, microscopes.
Yeah.
To maybe change our posture. So just some thoughts on how can we optimize ourselves training-wise and by using a little bit more of our body and brains rather than just monofocally doing a single activity.
Yeah, that's a great question. And I think it has to start early in training. I think we get to do a better job of identifying, and we've done it so far, what are the positions that we are in the most pain and where do things hurt the most? And then I think that we need to lean on our older colleagues who've also undergone sort of the same struggles and learning curve. Okay, what has been done before? How have they shifted their positions over time? And I think physical fitness does have some aspect, but the difficulty I have with physical fitness is training is we sort of learn to push through the pain to a certain extent. And I don't know if that's what we really want to do in surgery right now. But certainly sort of muscle strength and stamina are important. But you just have to recognize when something hurts, we don't always necessarily want to push through it and trying to find positions that we are more comfortable and then sort of adapting and working with our industry partners to adapt instrumentation and sort of enabling tools to help us maintain that position.
Dr. Sansa, you showed me some cool loops, and one of your residents who then was a fellow with us actually wore those. Can you tell us a little about these prism loops?
Yeah, I guess they have these loops that allow you to steer to keep your neck neutral, but look down on the field. And I haven't used them, but I'm interested in trying them perhaps. Yeah, you have them?
I've used them for about 3 months. It's similar to, I didn't use loops for about 12 years before that. And I used them for about the last 3 months. It's been actually quite helpful. They're not very heavy, and there's basically like having a microscope there, but you don't have to have it in. It's pretty nice.
It is sort of funny with those loops. I've operated with people who use those loops. You have to get over the fact that it looks like they're looking at you during the entire operation and they're staring at you because their eyes are there, but they're really looking down.
So. Well, hey guys, it's David Okonkwo. Kojo, do you want to comment on this? Because you've been operating with those loops for quite some time, and you've inspired several of our young residents to start their careers with those loops rather than adapting to those loops.
I think it's important that we migrate towards those loops. I wish they could have some degree of angulation to them because some people's natural posture doesn't portend well for them. So it's a really try before you buy. I've been using it for 3 years now, and I'm just waiting for it to explode in the market. But yes, it's great.
I think this is a great talk. It really is, because it illustrates, well, it's kind of like us as our patients. How do you put patients on the operating room table? You put them in some kind of neutral, it's like an athletic position that we should position ourselves to be in. Okay, I quit wearing loops. I just use a microscope. I mean, I try and do everything at some 90-degree angle. I think that, and having had a couple of back surgeries, I don't want anymore. Having had 5 shoulder surgeries, I don't want anymore. It's incumbent upon us to kind of protect ourselves, but it's data like this is great. Thank you very much, Philip. It really is an important one that we have self-preservation, because nobody else is going to look out for you.
Yeah, the one thing I wonder is you know, when I use my regular loops, I also look outside of my loops a lot. You know, so I wonder when you're using those prism loops whether feel like you lose your sort of peripheral vision to some degree. You know,
There's probably one more point about the ergonomics of all the instrumentation that we use, and I complain about it all the time, but nothing's been done, is that if you're putting big hardware into people, which are the really demanding operations we do, most of those things are so long. I mean, they're bad for your shoulders. They're bad for everything. I mean, we need to have instruments that we put in implants and things like that make it actually much more appropriate environment for our ergonomics.
Great talk. Thank you. Really many great points. Let's go for it.